Everyone. Happy Saturday. Welcome to Dr. J's Prescription for Health. I'm your host, Dr. Malea Jensen. I am a family practice physician for 27 years. I'm located in Des Moines, Iowa. So this is your opportunity to ask questions and discuss your medical concerns. But as a disclaimer, I am a physician. You guys are patients, but you're not my patients. This is for information purposes only, maybe a little bit of humor and entertainment, but this is not medical advice. So please discuss all things with your personal physician, okay? Just as a disclaimer, I wanted to get that out in the open. I do have a passion, and that passion is to help you prevent disease rather than medicate your disease. So prevention over medication. So with that being said, I thought today we would talk about a few topics. Again, this is your opportunity to ask questions, so please chime in. If you have any questions that you would like to ask in regards to your medical concerns, but the topics I wanted to talk about today was fat as an endocrine organ. I wanted to talk a little bit about insulin and fatty organ disease, specifically fatty liver disease. And I thought we would also talk a little bit about fasting because you guys are always wanting to hear more about that. But with that being said, if you guys want to interject, you have questions. The first question I have, oh, by the way, I am live on Instagram and YouTube right now. So we have questions coming in from both areas. The first question is, what is the function of cholesterol and why do we need it? We've been told so much that we need to lower our cholesterol with medications in order to avoid heart attacks. Very true. That has been told to you, and I don't think that that is necessarily true. I think that LDL and cholesterol are way down on the list as far as what is causing heart disease. But what are the functions of cholesterol? Well, cholesterol has many functions. I will give you just a few, but just remember that cholesterol is needed for all of our cells, all the cell membranes. You would not have a cell with a cell membrane if you don't have cholesterol. So cholesterol also helps with sex hormone production. So your estrogens, your testosterone, progesterone, those things, you need cholesterol. You need cholesterol for the production of bile acids, bile salts. You cannot have bile from the liver without cholesterol. That's how we make it. And so if you don't have bile, then you're not going to be breaking down any fats or doing the things that bile does. Also, another big one that you guys are, good morning guys over on YouTube. Another big one for why do we need cholesterol is vitamin D production. You guys know that vitamin D is very important. Well, without cholesterol, your production of vitamin D is almost non-existent. What about your immune system? Do you need cholesterol for your immune system? Absolutely. So you can see these four or five things and the actual function of your cells and having a membrane, so having a boundary, a border, you cannot do without cholesterol. So those are the importance of cholesterol. I don't know, if you guys have more to say about that, let me know. But let's get into, let me make sure I didn't miss any questions while I was talking about that. Good morning, Lucy. I'm glad to see you here. Hopefully you are feeling well, doing well. As for all of you guys, I don't know what's going on in your lives, so it's, you know, everybody's got their baggage. Everybody's got their things, and I'm one of those people too. I got things going on in my life that is baggage, but you know, we all got to work together, help each other. And right now we're going to talk a little bit about health. Good morning, Jana, and God bless you. Let's talk a little bit about fat as an endocrine organ. You might not have ever heard this, and it might come as a surprise, but yes, fat is probably the largest endocrine gland. It rivals the thyroid. It rivals the adrenal gland. This fat it's a huge endocrine gland. It has many, many, many functions. It does, in order to be an endocrine gland, it does release hormones. Some of them good, some of them bad. We don't always think of the fat in us as an endocrine organ secreting hormones, but let me just give you an example of a good hormone, a hormone that that is necessary for reproduction, and that is leptin. Now, many of you think of leptin as the satiety hormone, and yes, that is, but granted, if we do not have leptin, you are infertile. So you can't have, or your chances of getting pregnant are much, much less. And so if fat produces leptin, that means we need to have fat on our body in order to produce it. Another one that might not be so good is something called tissue plasminogen activator inhibitor 1. That is a hormone released by fat, especially visceral fat in the liver, and I've talked about this many times, that can increase our risk of developing blood clots because it actually blocks the natural breakdown of blood clots in our body. So something in fat can be really, really bad. Adiponectin can be really, really good. So each hormone that is produced by fat can have some good things and can have some bad things. All right? Now, when we discuss fat on our body, most of you think about it as cosmetic. Lana, I don't know what is going on with your screen going black, but that's got to be on your end because I'm not seeing any troubles with Instagram or YouTube right now. Okay, so how and what is the purpose of fat besides these hormones? Well, it can act as a buffer for protection, right? I mean, if you fall on your butt, a fat butt is going to protect you better than a skinny butt, right? What about your heat and cooling production? So the more fat you have, you might be able to adapt to colder temperatures better. It is also a storehouse, and we don't really think of it like this, but storing fat is important for energy. That's why we need it. No, Lana, I have not blocked you. So I don't know why you're having troubles. I apologize if you are. So this fat on our body is used as an energy source. But many of you guys, or you know somebody, that they never get to burning fat. And why is that? Because insulin levels are elevated. When insulin levels are elevated, you cannot burn fat. In the presence of high insulin, you cannot burn fat. So you will never dig in to your fat stores. I've seen this over and over again where, you'll have some overweight people or obese people and they're going for walks or they're going for hikes and you're out doing the thing, watching and looking and enjoying the scenery, and you see these overweight people eating energy bars or stopping for breaks, and they think that you're going to be, what do I say? You're going to need the energy, so you bring these bars and you continue to eat, knowing well, you don't know, but I know you will never start burning your fat for energy. So you go on these hikes in order to burn fat, but yet you continuously eat during these times. So if you're continuously eating, your insulin level is never coming down. Again, you can never burn fat in the presence of high insulin. And this goes for anybody. If you are overweight and you have excess fat on you and you're not diving into those stores, it's because you're not lowering your insulin. How do you lower insulin? You can lower insulin by fasting. I don't know if I would recommend that for an overweight person, though, who's used to eating, and I'll get to that in a minute. You can also burn fat simply by lowering your carbohydrate intake. So why is it harder for a person who's overweight to burn fat in a fasting state? Why is fasting so hard for an overweight person? And I would in simplistic terms, tell you that it is because of their insulin level. When an overweight person begins to fast, their insulin levels are so high that it drops their blood sugar really, really fast. And so an overweight person with high insulin, or just anybody with high insulin, when the blood sugars drop, you get cravings right away. And that is hard to overcome. Usually within 1 or 2 hours, that first initial type of hunger goes away. You basically fight it off. Then the next stage of hunger is that hunger that's over days to weeks to months. We can fast for months depending on the amount of body fat that you have. You know, decades ago, there was a study that was done on somebody, I believe it was in Scotland, who was over or around 600 pounds, and they did not eat. Now, it was medically supervised, and the person, I believe, you know, I don't know all the details, but I think they were on electrolytes and water, of course, but they used their fat as an energy source for over 365 days. I mean, could you imagine having that much energy stored up that you don't have to eat for that amount of time, over a year? I mean, it's just simply amazing. Now, if you are a person who's very lean, you don't have much fat on you, I don't think that it is in your best interest to fast for extended periods of time. And that is because once the fat is gone, you will start burning muscle. Your muscle is very precious to you. Muscle is the organ of longevity. And so if you are somebody who's lean already and you are going to fast, and you're going to fast for over 12 hours, 16, 48, 72, this is not in your best interest, because you're going to start digging in to muscle. You don't have any fat on your body in order to produce ketones. Now, are you going to produce a little bit of ketones because you're going to try to increase glucagon from your liver? It's possible, but I don't think I would want to risk it. I mean, I work very hard to try to get my muscle. And yeah, I think it's very important that you not fast for extended periods of time when you are already lean. Now, you can if you want. I'm just telling you that is not something that I would recommend. When is it possible that you could actually have high insulin and be breaking down fat at the same time? I just got done telling you that in the presence of high insulin, you cannot break down fat. In the presence of insulin, you will keep your fat and you will burn carbohydrates. You'll burn sugar. So high insulin, burning sugar. Low insulin, burning fat. When is that scenario not true? Well, if you are severely metabolically a disaster, you will be in a state where your insulin is high and you're in a state of lipolysis. How can that be? How can that be that when insulin is high, you're breaking down fat? And the answer is the fat cells have become resistant. They cannot get any bigger. Remember, when we consume foods, especially sugars, carbohydrates, insulin goes up. Insulin will drive that sugar into cells. Well, insulin doesn't drive it into the cells. It activates the receptor on the cells, okay? But with that being said, when insulin is high, energy is driven into the cell, or it's delivered into the cell. If that fat cell is getting too big, it's getting big, it's wanting to explode, just like a balloon full of water or air. It's going to explode. So that fat cell, when it becomes resistant to taking in any more energy, will start to leak. And one of the things that it leaks is fatty acids. So fatty acids will go into the bloodstream. That's called lipolysis by any other name. It is breaking down fat. You're breaking down fat from the fat cell, even in the presence of high insulin. That's pathologic. That is a metabolic mess. It's a disaster, you guys. That means that you're farther along than you'd like to be as far as metabolic health is concerned. And it is very dangerous. It's high risk for chronic diseases such as heart attacks, high blood pressure, dementia, those things, okay? So with that being said, I want to jump into fatty liver or even the fatty organ disease, okay? Because if liver is getting fatty, you know darn well that all your other organs are getting fatty. Fatty pancreas, fatty kidneys, fatty heart, fatty tongue. All of these things can also get fat. Lay down. So it's important to note that, yeah, fatty liver is not the only thing. Now, what causes fatty liver? Fatty liver will get fat because of insulin. So again, this is a small part of how fatty liver accrues, is you're eating carbohydrates full of glucose and fructose, and the excess is causing fatty liver disease. It's laying down excess. So fat cells are getting fat in the liver. The other way that I just got done mentioning is those free fatty acids that actually leaked out of the cell, the fat cell, go to the liver and cause fatty liver. So you got two ways that the liver can get fat. Its own way, lipogenesis. And the other way is the fat cells in the periphery leaking free fatty acids, triglycerides, into the bloodstream and going back to the liver. Again, both of these things are pathologic. One, I think, is greater than the other, but these are the things that you got to keep in mind. And fatty liver, I've talked about this many times. The liver is the master organ. It is a master organ for our immune system. It's the master organ producing bile. If it gets sluggish, guess what? You get cholestasis. If it gets sluggish, guess what? Glutathione can't be produced. There's so many things that can back up the liver and cause problems besides just fat, but the fatty liver is choking it out. So all of the liver functions are not working. And eventually that fatty liver, the fat chokes up that liver and it makes it hard. And that's called fibrosis. And there's stages, 1, 2, 3, 4. That fibrosis is basically hardening of that liver. And that hardening can advance to cirrhosis, which is basically death of the cells. Or worst case, you get liver cancer. And that's not a good thing. So reversing fatty liver is possible by lowering insulin. It seems really easy. I know. It seems like, gosh, this is simple. Why don't I just lower my insulin? But when I tell you how, you have to stop eating carbohydrates. Now it says, I don't think I can do that. Well, sure you can. It's just going to take some effort. Also, reducing visceral fat. There's been some studies that show that doing high intensity interval training, like sprints, can reduce visceral fat faster than prolonged cardio. And I talked about that last weekend. And so I just want to hit home on that if we're going to try any type of cardio, doing sprints would be in our best interest. Now, that sprint doesn't necessarily mean I'm going to take my big body and go run it on the pavement. Maybe that looks like the rowing machine. Maybe it looks like the elliptical machine. Maybe it looks like sprints on a bicycle. All of these help to decrease visceral fat, including high tongue fat. So speaking of tongue fat, the biggest cause of sleep apnea is getting a big tongue, fatty neck, fatty mouth or throat. And that's what usually leads to our inability to get oxygen to where we need it. So fatty tongue is huge, and not many doctors even know about this. But you look in their mouth, and we have grading systems. When we look inside your mouth, we have a grading system. It's called the Malea Jensen score. And we look in there, if it's wide open, like I can see everything, your hard palate, your soft palate, your uvula, I can see the back of your mouth and down past the base of your tongue, that is almost like a 0 or a 1. But you'll look in some people's mouth, or I will, or you could too. You know, you look in a family member's mouth and you look in there and all you see is tongue. It's like you can't see their teeth even. It's so congested. That is very high risk for sleep apnea. And then sleep apnea, of course, leads to heart attacks or high blood pressure or worsening of diabetes or prediabetes or just insulin resistance, because these people are not sleeping. So they are lacking, you know, brain rest. And so during the day, in order to stay awake, guess what they do? They'll eat calories, they'll drink calories, they worsen their problem. So sleeping is very important. If this is, you guys, if this is eliciting any questions, any medical questions that that you have, let's hear it. I want to see your questions, okay? Good morning, Kashua. I'm just kind of reversing and making sure I didn't miss anything. Touch of Wood, good morning. Good. Okay. All right. So moving along, I just wanted to go over the fatty liver, because one of the biggest questions you might have is, how do I know I have fatty liver? Well, there's physical changes in your body, meaning a protuberant abdomen. That's indicative of fat that's growing inside your body and pushing outward. Okay? It's pushing your internal organs outward. So a beer belly or even love handles, you guys, that is an indication of fatty liver. How else can you determine fatty liver? A lot of doctors will look at your liver enzymes, like an AST or an ALT. Now we have to be very careful with this, you know, because these values can be skewed, or you can get a false positive. But normal values of AST and ALT is in the 10 to 15 range. Anything over that is stress on your liver, with one exception that I can think of just right now. If you had been strenuously exercising the morning of getting your fasting labs, your liver enzymes can be falsely elevated. That is why when you get your labs done in the morning, you should really not exercise for at least 48 to 72 hours. It is not necessary that you be exercising, because it's going to skew the results. Coffee will skew the results. So fasting for 12 hours, water only, take your medicines if you're on them. That is the perfect type of fast in order to get your labs. One other thing that you want to consider when getting your fasting labs is, don't get them, I don't think you should get them before 10 a.m. Why? Because your cortisol level is elevated. And that's a natural thing. When you wake up in the morning, your cortisol is high. It's getting you ready for the day. When cortisol is high, your glucagon will be stimulated to make blood sugar. If you wait until after the spike of cortisol, spikes of cortisol run anywhere from 3 a.m. to 9 a.m. Then at about 9 a.m., it starts to level off. Your cortisol will level off. So I suggest getting it around 10, maybe 11, fasting. But that means that you probably want to eat a meal around midnight, whether that be maybe just some cottage cheese and some bacon, something like that. All right. Yeah, Edward. Ed is over on YouTube. He has a question. He says, can you repeat what you said about AST and ALT good levels? Around 10 to 15 is a good level for AST and ALT. And I also suggest getting a GGT. It's a little more specific for that, okay? It's a little more specific for fatty liver disease. Same with ALT. AST is more indicative of environmental toxins. So ALT is more indicative of, hey, do I got fatty liver? But when the gold standard, you guys, the gold standard of checking for fatty liver disease is actually a biopsy. Doctors don't want to perform it, and I don't think you want to receive it. But what else can we do? We can get an ultrasound of our right upper quadrant. We can determine from our right upper quadrant, hey, do we have some fat wrapped around our liver? Or we can get an MRI, or we can get a DEXA scan. These are ways that we can for sure diagnose fatty liver. But if you got the abdomen, you got high insulin, and you have elevated liver function enzymes that you didn't exercise, they're not falsely elevated from extraneous exercise, let's say 2 to 3 days prior. Yeah. You guys, fatty liver is a big thing, and we really need to be diagnosing it, because the reason we're seeing so much fatty liver is because of our diet, because of high insulins. We got prediabetes, diabetes, we got metabolic syndrome. Lucy says, I got my mom's labs. I need to translate to English. Any advice on how to better do this? I do not know. In fact, I have some Canadians that are clients, and all of their, same with Italy, all of their values are in a different value system. And I have to sit and not translate, but I have to, translate them into American values. And so that is difficult, and it's very time consuming, but maybe, you're doing it for your mom, but for my Canadians, I ask that they help me and write down, like one of my patients from Italy, he and his wife will actually write down the values in American. They'll put them in parentheses. So if you Canadians out there who are listening, if you could do that to help me out, that would be great prior to starting our consultations, which segues me into talking about my consultations. If you are interested in having a consultation, going over your labs with me, please email me at IronLadyDoc@AOL.com, IronLadyDoc@AOL.com, and we will get you set up. I'll send you some forms to fill out to get you into my system, into the electronic medical records, to have a chart for you so I can keep track of you, is filling out these forms, and we'll get you going. And we'll get you put on the schedule, and we'll go over your labs line by line. Let's see. Lucy says, so happy to have watched your interview on YouTube, Baker Family Fitness. Did I get that right? Yay, you go, Dr. J. Yes, you did get it right, Lucy. I am actually helping out with Baker Family Fitness. They are in Canada, and that's why I'm getting more. Now, I had some Canadian clients already, but now I am kind of helping out Baker Family Fitness, going over her clients' labs for her. I think, she's asked me to do that because, one, it's very time consuming for her, and two, she thinks that having a physician going over the labs would better suit her clients and the programs. Now, if you're interested in Baker Family Fitness and the programs that Krista and Mike have, most of it can be done online. You do not have to be in Canada. They're in Ontario. You do not have to be in Canada to join their programs, just like you don't have to be in Iowa to join or to set up a consultation with me. We, as you guys know, the internet is opening up all kinds of avenues to help people. And so, yeah, joining with Baker Family Fitness is a win-win, because the information that I give to the patient, to the client, will help them and Krista and Mike form a program that better suits the client. If I'm, telling the patient that perhaps they got fatty liver disease, Krista and Mike might not go tell that person to go on a 4-day fast or even incorporate fast yet in their program, because their insulin levels are high, and you're setting your patient up for failure. They're going to be too hungry, and they're going to get into a fast or a purge binge scenario. And basically that's just an eating disorder, you guys. most people who are obese already have some sort of an eating disorder. They're binging and may not be purging, but they're binging and then fasting and then binging and fat, and they cannot do it because their insulin level is so high, and then it drops their blood sugar the minute they stop eating. So going on a slower ketogenic diet is in their best interest, and this helps Krista and Mike set up their program. Okay, and the more information they have, the easier it is to set up that program. So having me on board, and it's not really, they're not paying me. I'm not working for Baker Family Fitness. They're not working for me. We are just basically collaborating. We're helping each other out. My passion and my expertise is helping the patient learn about their chronic diseases and what the labs can show. Now, if we need more labs, I'm going to encourage them to say, hey, you need to get this. Can you get this lab? It'll help me better evaluate your labs and evaluate your health and your medical conditions. Then I send that back to the patient, and then they can talk to Krista and Mike about their program. This is how this works. Krista and Mike do some things that I'm not well versed in, and so I don't want to do the things that they do, and I'm not an expert in it, and they don't want to do what I do. They're not an expert in it. So it works great. So I appreciate Chat with Lucy. I appreciate. So if you're interested in what the programs are, go to bakerfamilyfitness.com, I believe, and review it, sign up, and see what they can do for you. Lucy, I did read your the Modic type 2. I don't know. I would have to look that up to give you a better idea. I did see it. I did not comment on it. I apologize. Okay, but again, I would after looking it up, I can help you. So you can email me or text me, and I can see where I'm at with that. What other? I talked about as a review, you guys. I initially opened up with a question in regards to cholesterol, and what is basically the functions of cholesterol, and what is the risks of having coronary artery disease because of high cholesterol. And I think doctors are learning that looking at cholesterol or even LDL, or God forbid that we're eating saturated fat and it's causing coronary artery disease, I think that doctors are starting to catch on. We are, we are starting to realize that eating saturated fat is not the cause of your coronary artery disease. But it didn't alleviate the fact that most doctors still think that cholesterol and LDL is the cause of coronary artery disease. I don't think that this is true. I'm not saying that LDL and cholesterol is not a factor in the plaquing of coronary artery disease. I didn't say that. Don't hear me say that. I just don't think that LDL caused the initial start of your plaque. I believe that an injury to the artery lining occurred. I don't believe that LDL just happened to get embedded into your vascular wall and cause increased plaquing. I think that there are things that increase injury. They provoke an injury in the lining. And when that lining is disturbed, the innermost lining, that glycocalyx, and then the endothelial lining, when they get damaged, injury occurs and then patchwork starts. That patchwork can look like calcium. And if we aren't able to alleviate that injury, so the patch gets bigger and bigger and bigger because we continuously injure, then we're at risk of artery narrowing. Now, with that being said, in order to qualify as an artery narrowing significant enough to cause a heart attack, it has to be 70% or greater. That's why when you go get an angiogram and they say it's less than 49% occluded, when you're going, well, what if it is 49%, or what if it's 48%? That's halfway occluded. Well, that percent occlusion doesn't quite register for or qualify for a blockage in an artery. If it's got 30% blood flow, it's likely to have enough blood flow that it's not going to cause a heart attack. Also, at areas where there is narrowing, we start developing collateral flow. So you might note, and just ask around, ask people, most people who have a heart attack, it did not occur at an area of narrowing. It actually occurred somewhere else, and it was due to a blood clot. So many docs, many PhDs, physicians, whatnot, believe that the infarction is due to inflammation and blood clot formations rather than the actual narrowing. Okay? Most narrowing occurs at areas of bifurcation because the pressure is higher in these areas. And pressure is one cause of artery damage. So's sugar, so's insulin, so is smoking and alcohol, so's heavy metals and nanoplastics. All of these things can increase or provoke an injury. And then once that injury is provoked, it's almost like things go to that area to patch it up. It could be red blood cells and white blood cells. It could be fat and cholesterol. It could be fibrin. All of these things go to an area to help patch up something that is being damaged. Now, if you only smoked one time, likely your ability to patch that up and heal it is A-okay. See, whenever an injury to an endothelial cell occurs, our bone marrow starts to produce progenitor, little baby endothelial cells that go and replace the damaged ones. It's a normal process in our body, unless, of course, something's wrong with the stem cells or the bone marrow, or you got constant damage going on and the baby cells can't keep up. Or the ability to break down that plaque, that blood clot, can't keep up. That means you're smoking all the time, you're drinking all the time, you're eating sugar all the time, you're having exposure to heavy metals all the time, you're having exposure to nanoplastics all the time. Until we can stop the injury, the provocation, we're going to continue to build up injury. And that's why they say that plaquing gets worse as we get older. That normally it's your arteries are just going to get older and they're going to develop plaque. I can't disagree with that, but I have seen people with calcium scores of 0 into their 70s and 80s. Now you might ask, why are they getting a calcium score that late in their life? I mean, they've lived a good life. What are they going to do about it at 70 or 80? I can't answer why a person would want to do that, but I'm not going to deny them if they want to have a calcium score. They might think that they're going to live to 120 because their telomeres say that they can live that long, and they want to do it, and they want to see, hey, is whatever I'm doing, is it helping? Or is it just a waste of my time? Maybe I'll just go back to eating carbohydrates and polyunsaturated fatty acids in the form of linoleic acid. So, again, there's multiple ways that we can look at our risks of having coronary artery disease, but I don't think LDL is one of them. If you guys want to get an advanced lipid test and you want to decide, hey, do I have those small, dense LDLs that everybody's talking about that cause coronary artery disease? Again, they don't cause coronary artery disease. They are causing or adding to the injury. What makes a small, dense LDL pathologic is the fact that it's oxidized. And it's oxidized because of usually high blood sugar, or which is high insulin, or high PUFAs, polyunsaturated fatty acids, especially omega-6 linoleic acid. All of these things, toxins, so to speak, oxidize small dense LDLs and cause them to be pathologic, meaning those are the ones that are at the scene of the crime. They're helping out, leading to plaque formation. It's important to know that the plaque formation in your arteries, when you get a calcium score, that score doesn't equal a percentage of narrowing. Get that out of your head, that because you have a calcium score of 100 is that you have a certain amount of plaque. That's not what it's telling you. It's just telling you a score of, hey, you got plaquing. It's not 0. It's 100, or is it 400, or is it 600? Is it 1,000? That 1,000 puts you at very, very high risk for coronary artery disease. Can it regress? I believe so. How? You need to get your carbohydrates down. You desperately need to get them down. Dennis says, I have a new doctor appointment in a month, so I'm going to set up a consultation with you to get lab order. You said for the insurance to pay for the labs, there should be corresponding diagnosis. Is that correct? Yes, but Dennis, I cannot order your labs because I no longer am on insurance. I'm not on their insurance programs. I cannot order your labs. If I order your labs, insurance will not pay for them. So I can give you a list of labs that you should get that would be beneficial for you to get, and ask your new doctor to get those. How about that? Okay. Here's a question on regards to the calcium scoring test. If you have a calcium scoring test that comes back at 0, when should you get it again? That's a great question. And there's going to be a lot of different answers. My answer, I think that you should get it maybe in 1 to 2 years, because I want to know whether or not you have progression. Now, somebody else, another doctor or a cardiologist might say, hey, I think getting it every 5 years is adequate. Some of you, that is way too long, and you want to know, oh my gosh, is my 100 calcium score, is it now 120? Normally, you can expect that your calcium score is going to go up 10% per year. So if it was at 100 and you recheck it in 1 or 2 years, you could possibly expect it to go up to 110. But what if it's 160? Now it's over that normal, that the average rise in calcium score over 10%. Now you're at, 16%. That's pathologic. I've seen some go from 100 to 200. That's really bad. I have seen people who have a calcium score of 100 and they go on a carnivore diet and it's actually regressed. And that really helps people know, oh my gosh, this carnivore diet is working. I am getting some plaque regression. Or it's actually stable. It stayed at 100 and you say, oh gosh, that's not good. Well, actually it is, because it didn't go to 110, right? So we got to look at the small victories here. All right. That's a great question. The calcium score, again, there's another test that people are saying, okay, well, the calcium score is not completely accurate because it can miss plaquing. Yes, it's not going to be specific and what's the other word for it? Well, anyway, it's not, it can't be completely accurate. Is there a more accurate test? There's been some talk that the clearly scan is even better than a normal calcium scoring test. Now, I do not know how much that clearly test costs, but a calcium score is right around $100, and not every insurance will cover it. In fact, many do not cover it because they don't see the value of it. All right. So getting a calcium score is not an end all be all. However, it's great in terms that it's non-invasive. You guys might beg to differ and say, well, but isn't it radiation? I'd say, yeah, but it's real quick and it's less than a lot of other radiations, like a CT angiogram. What's the difference? Well, a CAC score measures calcified plaque, versus a CT angiogram will measure soft plaque. Which is worse? I think soft plaque. It can break off, and it's that blood clot that goes and causes heart attacks. The inflammation can be present in both areas, both in calcification and in areas of soft plaque. So we got a part of our artery that's injured, it's inflamed, you got some plaquing starting, and there's some things you can do about it. It's not completely a poor prognosis. Now, if you have a calcium score that's less than 100, your risks of coronary artery disease are pretty low. If it's between 100 and 200, your risk goes up. If it's upwards to 400, you're high risk. If it's greater than 400 to 1,000, you're at higher risk. And don't quote me on those percent or those levels, but you get the idea that the higher the calcium score goes up, your higher your risk goes up. I don't always order CT angiograms on people, but if they ask, I'm going to order it. If you are having a calcium score and say it's 1,000 and you're having symptoms of angina, so chest pain, you're getting some ischemic changes. Your blood flow to that area of heart is low. And most doctors, cardiology-wise, they'll look at your CAC score, they'll look at your symptoms, and then they'll do an angiogram in the cath lab. And that's going to be the gold standard, okay? These are good questions, you guys. I appreciate it. Dennis, will my new doctor need to provide a diagnosis to write your recommended lab order for insurance? There's going to be multiple diagnoses, Dennis. You can't just put coronary artery disease to get everything paid for. There are diagnoses that will pay for a lipid panel. For instance, high cholesterol or hyperlipidemia will cover a lipid panel. Simple as that. And hyperlipidemia will sometimes, in most cases, cover a CMP, a complete metabolic profile, because you may or may not be on a statin and a statin will pay for a CMP. It's hard to get into all of the diagnoses, but your doctor should be bright enough that they know to put a diagnosis code at each spot when they're writing the lab order. So for instance, Dennis, if I'm going to order a CMP, a lipid, an A1C, a thyroid panel, things like that, I'm going to tell my nurse to order these things. And then she, not the doctor, but she is good enough that she will, because the computer system provides for her some opportunity to plug in a diagnosis. If it says no diagnosis cover this particular reason for getting this particular blood test, that's when it goes over to you, Dennis, and you will sign you'll sign, if you're a Medicare patient, you're going to sign a form called an ABN. And that means that you have signed away your life, that if they fail to put in a correct diagnosis or a diagnosis at all, you will pay for it. So if I want to get a thyroid panel and I want to get a CBC and I want to get an A1C and I want to get these things, fatigue pays for a lot, if not most, of the labs. Fatigue on its own will pay for a thyroid panel, but you have to have not just a thyroid panel, just a TSH. You need to be specific. I want not just a TSH, I want a free T4, I want a free T3, I want a TPO and a TG, and I want a reverse T3. That's the whole panel. I don't want just a TSH. Oh, your insurance isn't going to pay for it. Seriously, just do it, doctor. Plug it in, put fatigue down, and see what it'll pay for. Like, my nurse is really very good about adding more diagnoses. if you have a diagnosis of hypothyroid, you better put it in. Or if you have Hashimoto's, put the diagnosis in along with fatigue. Fatigue will pay for a CBC. So will macrocytosis or microcytosis. So if you look at the MCV on your CBC, the Mary Charlie Victor, so MCV, if it's over 89, you have macrocytosis. D75.89 is the code that you would use for macrocytosis in order to get the CBC paid for. If you have microcytosis, if it's less than 85, the MCV, then you have microcytosis, and you can put that as a diagnosis that pays for a CBC. You would think that your doctor is bright enough to help you out getting your labs paid for, but maybe it's not the doctor. Maybe it's the nurse doing all of his grunt work, and she's plugging it in, and he goes, well, you know what? He signed an ABN. I really don't care. That is the way of our health system. They don't care about your money, and they don't care about ordering your tests that you want. It's really a shame. So you have to be very vigilant about how you're ordering it. Coronary artery disease, if you have a diagnosis of coronary artery disease, like you've had a previous heart attack, or you've had previous stents or an angiogram or something like that, that indicates blockages, whether that it's obstructive or non-obstructive, it should pay for some of these things. Even if you've had, like say you want a CRP, a high sensitive CRP, coronary artery disease will pay for a high sensitive CRP because it's highly sensitive for heart muscle inflammation. So getting a high sensitive CRP should get paid for. What if you've had an elevated CRP in the past? That will pay for it because a diagnosis could be elevated or high CRP. The doctor has to put these things, and it's going to take, you knowing what your diagnoses are in the first place. So you just said you got a new doctor. Do you have the old diagnoses? Did your previous doctor have your old diagnoses? And besides each diagnosis, there should be a code, an ICD-10 code, like hyperlipidemia has a code, R53, I can't remember, R73.2 or 70, something like that, 71 point. I can't remember all of the codes. Sometimes I have to look them up, but usually they're in your chart. And so if your doctor has all of those diagnosis codes, then you're able to plug them in and they should cover your labs. But if they don't, whoever's putting the labs in doesn't match it up with a diagnosis code, and they just push skip, they'll just skip over it, they're not helping you. That is not helping you whatsoever. That's causing you to be paying for a lot of labs. Now, if you come to me and say, my doctor won't order any of these labs, and you need somebody to order them, then, by all means, come to me, I'll order the labs, but it is self-pay, and it could cost up to $350 or less, or, I haven't seen any really over $327. The highest amount, the biggest panel that I have ever written was about $327. And do some of you guys want that panel? Yes, that's great. I order it. Maybe like a milder form of my panel might be about $250. So you have to keep in mind that when I order panels for people, I'm getting a discount. So dentists, if you go to your doctor and they order a test, you're not getting a discount on that lab. So you could be paying full value. So instead of paying like a 40% discount like you get with me, you could be paying full 100%, no discount. So a lipid panel instead of $10 could be 20 or 25, and that adds up over time, dentists. So please keep that in mind, that your lab, wherever they're ordering from, they aren't going to give you any discounts. They're charging you full price as if they were charging the insurance company. They charge, I know this sounds confusing, but let's say you come to me and I charge $300 for the visit. The insurance company is going to tell me that that visit is only worth $100 and they might only pay me $75. So no matter what I charge, okay, you're going to only have to pay, less than $100, whatever the insurance company deems that I'm worth. Now, what if your insurance company doesn't approve of you getting a lipid panel for any reason? Then they say it's not payable. Now so if the lab charged you $30 for the lipid panel, guess what you're paying? $30. If the insurance company says, okay, we'll pay for the lipid panel, but it's only worth $20 and I'm only going to pay the lab $10. I hope this is making sense. But if your insurance company isn't on board with what is going on, they can deny all coverage. They're not going to cover it. And then you foot the whole bill from what the lab is charging. They can charge you $300 for a lipid panel. Guess what? You could end up paying $300. Unless the insurance company steps in and says, hey, that lipid panel is only worth $25 and here's what the patient's going to pay for, then great. But still, I could have gotten it for $10. So know these things before going in. Here's a question over here on AS. Are you familiar with myostatic related muscular hypertrophy? I am not. So I apologize for that. Another question. What are your thoughts on taking estrogen? I noticed bladder leakage, something a few days before my period, but only then, and my PF is super strong. PF. Was hoping this may help. I'm almost 45 for a reference. I don't see a reason to take estrogen at all. I think that if you are closing in on menopause, if you are eating a diet that supports the natural production of estrogen, you shouldn't need to take a synthetic plant-based estrogen. I'm not on board with taking it, even if it's vaginally only. I'm not on board with synthetic anything. Why not let your body do these things? Why are we trying to just continue to take medication? Remember, my passion is prevention over medication. And here we get a symptom. You're not even trying to prevent it. You get a symptom, bladder leakage 3 days prior to your period, and you want to give yourself estrogen. I can't get on board with that. Now you can, and that's fine. You wanted to know my thoughts. Those are my thoughts. If you are obese and and are becoming menopausal, guess what? You already have hyper estrogen in your body because it's in your fat. Your fat is storing estrogen. Whether you're a male or a female, you have stored up estrogen. You do not need more estrogen. You need to burn your fat and use that estrogen, but it's dangerous to add on more estrogen to a person who already has enough estrogen. Taking synthetic hormones, and they tell you that they're natural. They're not natural. They're from a plant. We're an animal. We don't assimilate plant cholesterol into our cells. You might initially get some improvement, but that improvement will not last, and could be harmful. Anything synthetic or anything that messes with our normal biologic or physiologic pathways, like taking estrogen or taking testosterone for that matter, is messing with a normal biological or physiologic pathway. It can be pathologic. I can't get on board. The way you can increase your normal production of estrogens or progesterone or testosterone for that matter is to eat a high fat, animal fat diet full of fat and cholesterol. It's that cholesterol that is needed to start the hormone cascade that begins with pregnenolone. And pregnenolone can make your progesterone. Pregnenolone can stimulate the adrenal glands to make DHEA. DHEA converts to androstenedione, and androstenedione converts to testosterone. And testosterone converts to estrogens. All right? And that's, if you have aromatase enzyme working, you can, break down the testosterone into estrogen. All estrogens start out as an androgen. So all estrogen has to first start out as a testosterone. You don't just get estrogen, but what you're insinuating is that I'm just going to take the estrogen. Well, what kind of a negative feedback is that going to have on your normal body systems? I would do it naturally. Dennis, it doesn't matter if it's a doctor or an NP, nurse practitioner. Dennis says, if I pay for the labs and consult with you, do I really need to physically see a doctor? I currently see a cardiologist once a year. Dennis, that's up to you. In all reality, no. If you're seeing the cardiologist and they're actually listening to your heart and listening to your lungs and measuring the amount of edema in your lower extremities, I mean, really doing a physical exam, did they look at your ears? Did they look at your mouth? Seeing a doctor, a primary care doctor, they look in your eye or your ears. They're going to see if there's any wax in the canal. They might try to get that out. They're going to look at your mouth. They're going to look at your dentition and your gums. They're going to look at the size of your tongue, or they should be. They should be looking at these things. Are they listening to your neck? Are they listening to your carotid arteries? Do they hear a bruit? Sometimes the cardiologist doesn't even listen because they think your primary care doctor's doing it. So listening here, are they listening to your heart? I mean, a cardiologist should listen to your heart, and they should listen in all aspects of the heart, all the way around, apartment N. They listen to the aortic valve, and they listen to the pulmonic valve, and they listen to the tricuspid valve, and they listen to the mitral valve. They got to listen to all these things, and they're listening for murmurs, and they're listening for these things. But honestly, you know what? You're reaching them and the cardiology states. They're just doing their thing. You're a recipe to them. If you complain of chest pain, they're going to do an angiogram. You're already on a statin. You're already doing the thing. Yeah, that's why I think it's important to see a PCP. Also, what if you need to go, what if your ears are plugged up? If your ears are plugged up and you got wax in there and they say, hey, I can't get this out, then you go to an ENT. Well, somebody like me who's not based with insurance can't refer you because your insurance doesn't accept my referral to go to the ENT to get your ears cleaned out. Now, some people's insurance says that, yeah, Dennis, I have plugged up ears. I'm just going to call the ENT. I'm going to make my own appointment. And many ENTs will accept you and say, hey, I don't need a referral. That's okay. Medicare sometimes doesn't need a referral. They can go to whatever doctor they want by simply calling them. So More Sunshine also says, I don't take any medications. And I've been doing pelvic floor treatments. So does that mean you're going to physical therapy, or are you just doing Kegel exercises, that sort of thing for 3 years, and you're thin? So your thinness can be a disadvantage for you because that means you don't have any fat. So that means you could not be eating fat. I know you're saying you're exercising, but it is important that we are eating enough saturated fat, not polyunsaturated fats, not omega-6s, not linoleic acid. That's not going to make good hormones for us. We need saturated fat and cholesterol to make our good hormones. Make sense? So somebody like yourself who's perimenopausal, I would say by your description, is eating perhaps a 1-to-1 ratio of fat to protein, or a 2-to-1 fat to protein. You might need More Sunshine. You might need even more saturated fat intake in order to get your fat and cholesterol enough to make estrogens, all the estrogens. Again, you know, you have to do what you think is best for you. Lucy says, my opinion, I do not recommend HRT. Lucy says, I had creams, a patch for years, thought I was doing healthy thing, wrong. She says, go carnivore, be happy and healthy. So that's an opinion from somebody else listening, More Sunshine. So Lucy is trying to add to it. More Sunshine says, I eat a lot of animal fat and protein. I don't know what a lot is. Let's just say you're going to eat 100 grams, or you know, you're 120 pounds, you're lean, you're exercising, and you maybe want to get 1 gram per pound of body weight. So you're going to eat 125 grams of protein, so 1 gram per pound, because you want to make sure that you're building muscle, you want to make sure your bones are strong, so you're going to do that. You might need at least 125 grams of fat, or upwards to 250 grams of fat. What does 250 grams of fat look like? It probably almost is 3/6 of butter. So I don't know what a lot is in your book, but a lot, boy, that's 300 or 250 grams of fat is butter, would be almost 3/6 of butter. 73-27 ground beef is about a 1-to-1 ratio. 80-20 is about a 1-to-1 ratio. So if you ate all of the grease and all of the beef for the protein, that is almost a 1-to-1 ratio. So all of that liquid that came out of there, you have to eat that too. No skimping. Or you say, I'm going to get 100 grams of fat and 100 grams of protein. I'm looking at just a little, you know, like 1 1/4 stick of butter a day. That is what I consider optimal. You might find that your pelvic floor is getting better. You're doing the exercises, you're doing the fat, and then you can start maybe decreasing the fat a little bit. But if you're thin and lean, you're putting yourself in an advantage, especially as you get older. None of us like to look at fat on our body. Well, I don't like to look at fat on my body, but I know it's a necessary thing to have fat on my body. But you can start tweaking things and burning some of that fat. Remember, lipolysis occurs in the presence of low insulin. But if we are consuming things that are elevating our insulin, and we might even not be consuming it, you might be so stressed, you guys, that your cortisol is always elevated and sugar is always being produced from the liver. And that can be a cause of increasing amounts of fat on our body. And it has nothing to do with the amount of fat you're eating. Okay? Let's see. These are good questions. Yes, you are going to physical therapy. Good. You know, there's another thing with physical therapy. I don't know if they can do like a type of TENS unit that goes inside of you, and it helps to stimulate that muscle. But again, you need to have healthy tissue. Atrophic tissue in the vaginal area or the pelvic floor is not healthy tissue. It's weak and it's getting fibrotic, scarred. And healthy tissue, you know, your physical therapist should be, or the gynecologist should be able to note this when they're looking at your tissue, whether it looks healthy or whether it looks atrophic. Simply having secretions is a healthy sign. So dryness is atrophic sign and weakening of that area. I don't know what it is about your period time that is causing it. I have to look that up specifically, but I'm guessing it depends on that timing and what hormones are present. Okay. You're eating bacon and eggs, great, but you might need more fat. More Sunshine says she's 5'10", 150 pounds, lift weights 3 times a week. All great things. All great things. Dennis says, thanks. I will get lab your recommendation and go to the nurse practitioner and what hoops I need to jump through. Great. Dennis, I would say one more thing. Here it is. Because when the nurse practitioner orders the labs and the nurse is plugging it in, there will be a red flag that comes up and says, this lab is not paid for. No, whatever diagnosis you put, it's not covered. The nurse or the assistant who's putting in the labs can actually uncheck that lab and not send it in. And so you won't be charged for it. And then you'll see what they didn't run, and then you can come to somebody like me and I can order whatever they didn't run. So it's another checkpoint, Dennis. Let me try to explain this again. If you go and you give them this list and you give them your diagnoses, and there is a lab that is ordered, say a uric acid. Say I want you to get a uric acid, but you have no diagnoses that'll cover a uric acid. And if the nurse sees that as a red flag, it says this lab is not covered, have her uncheck it. Okay? I can get it cheaper than what she can get it. Does that make sense? You have to maybe talk to the doctor and talk to the assistant who's plugging this in, because do you think that a doctor seeing 40 patients a day is going to take the time to explain to his nurse assistant what you're wanting and not wanting? No. He's moving on to the next person. He's not even taking the time to do charts in between. He's doing clickety-clack work at his noon hour and after hours. He can't even keep up. That's why he gets burned out. Okay. Dennis says he rebounds, and he also just looked up if it can help with the pelvic floor, and he said yes. So sunshine, maybe getting a rebounder will help. Okay. Oops. You're welcome, Dennis. I saw a question back here. Oh, it's in regards to ordering labs. Okay. All right. I get it. Here we go. There are certain labs that I think are relevant to at least get a baseline. Okay. If you guys are wanting to get a list of labs, just email me, IronLadyDoc@AOL.com, or just simply message me through Instagram or Facebook at Center Stage Primary Care, and I will get that list to you. Some of you are asking about NMR, basically an advanced lipid test. You want to know what the breakdown of the size and particle number. So an NMR, nuclear magnetic resonance imaging of your blood, is a lipid panel that'll give you the size of your particles, your LDLs and your HDLs. It'll also give you the number of particles, how many HDLs, how many LDLs, and then it breaks it down into the sizes of those LDLs. It'll even give you a value for Lp(a), which is supposedly the worst of the worst small dense particles. They will also tell you that it's hereditary. Having high LDL is hereditary, okay? They'll also tell you that you can't lower it. Yet, there are medications in the pipeline that lower LDL. So before taking a medication, do you think it's possible to lower your LDL, your Lp(a)? I think yes. Have I seen it? Yes, I have. I have seen it in people who go carnivore. I've seen it go down. I've seen inflammatory markers go down. So it's important that before you go before you go and take a medication, maybe you want to consider changing your diet. All right. Do you need an NMR? No, but again, some people like to know what their particle size are. If your particle size is all of large LDLs, I would feel better about that for you. And I think you should feel better about that. But if you get a test back and it shows that you have a high amount of small, dense LDLs, I'm going to tell you that you have metabolic problems. Because the only way to get that small, dense LDL like he is by eating carbohydrates. Your triglyceride levels will also be elevated. So you'll have a lot of small, dense LDLs, and you'll have high triglycerides, and you'll have a low amount of HDLs. That is from eating a high carbohydrate or carbohydrate diet only. If you stop eating carbohydrates, your small, dense LDLs the number will go down. the triglycerides will go down and HDL will go up as long as you are eating enough fat and you're exercising. Very good questions. None of these things are written in stone. But if I just had a simple lipid panel on you and I look at your HDL and your triglycerides, I can tell if you're metabolically healthy. Yes, those two values are like a roller coaster through the day, but for a general purposes, I can tell your metabolic health by looking at those two lab values, a triglyceride and an HDL on a simple lipid panel. I don't have to look at your LDLs because I already know what's going on. If your triglycerides are high and your HDL is low, you have a lot of small, dense LDLs and you are at risk for a heart attack. Plain and simple. If your insulin level is elevated, you're at high risk for a heart attack. The number one cause of having a heart attack right now, the way they describe it, diabetes. If your insulin level is elevated, you have underlying diabetes. You are at risk for a heart attack. You're at risk for dementia. You're at risk for cancer. You're at risk for all of these metabolic diseases. And it simply starts with changing your diet. Okay. Oh, Ruth from Iowa. Thank you, Ruth. She says, please define elevated insulin. Great question. Elevated insulin is anything over 5. Insulin in many circles, and you're probably listening to all of these kind of a ketogenic doctors or ketogenic influencers. When you hear the word insulin, and even me, you are thinking to yourself that insulin is always the villain. Let me tell you, insulin can also be a hero. We need insulin in order to survive. You cannot survive without insulin, i.e., picture a type 1 diabetic. A type 1 diabetic will die without insulin. They will eventually just die. You need insulin in order to survive. That is hero. It's just that we have more insulin than we need, anything over 5. There's no reason to have insulins that spike and stay elevated over 5 on a regular basis. It's not necessary. Now, if you went out and you're a carnivore person and you went out to a birthday party and had cake and ice cream, and then you measured your insulin level, which is very hard. It's a machine. I think Mojo is going to start getting where you can measure ketones, glucose, and insulin all in one shot. Whoa, that'll be great for people. It might already be on the market. But with it being insulin and you're hearing all negatives, the reason you're hearing insulin as a negative is because it's too high. You don't need that much, unless, of course, you are eating foods that elevate insulin and keep it high. Your body is only producing insulin in the presence of what you're putting in your mouth or such high cortisol levels in your body that it's doing it. Your pancreas doesn't just pump out insulin for no good reason. It does it when it senses too high of blood sugar. And most people who have high insulin, it's elevated chronically through the day. It's not like you being a carnivore and then going to a birthday party, it spikes and then it comes back down. See, the reason we say an insulin level between 3 and 5 is because that is what's needed to take care of the normal blood sugar that should be in our bloodstream at any one time, which is 1 teaspoon. 1 teaspoon of sugar throughout the whole 5 liters of blood in your average size body. That's all there should be in order for you to survive. But the minute you eat 1 piece of bread, puts it up to 3 teaspoons. And that's unbelievable. So you need to take care of the 3 teaspoons. Your pancreas secretes insulin. If you're constantly eating through the day a piece of bread or a little nibble here, or carrots, or whatever oh, it's healthy, a little piece of fruit, you just caused a rise in your blood sugar, and your pancreas responds by producing insulin. So if you're eating multiple times a day, throughout the day, except for when you're sleeping, your insulin level is staying chronically elevated, which puts you at risk. So now he's the villain. Now he's causing fatty liver disease. Now he's causing fatty tongue disease. Now he's causing diabetes. Now he's causing those fat cells to get big, 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 and then start leaking their innards. That fat is pathologic. If you are just like Sunshine, who's listening right now, if you're Sunshine and you're kind of thin or you're lean, right? And you don't have a whole lot of body fat, right? You're not holding a lot, or you just hold it on your butts and your upper thighs. That is not pathologic fat, you guys. That's the wiggly jiggly kind. That fat, those cells are not leaking. When they're leaking, they're way too big. They're getting so big, they're going to leak their innards. And then the whole body becomes inflamed. It all becomes inflamed. All right? That is pathologic. Liver fat is pathologic. Any visceral fat is pathologic. Tongue fat, pathologic. You basically have a tongue that looks like a ribeye steak, or worse, Wagyu beef. It looks like a Wagyu steak. It's so marbled inside there. How do I know? Get an MRI if you don't believe me. But your tongue should not be that big. And your belly will match. If you have fatty tongue, you likely have a protuberant beer belly. Or you look like somebody described it as SpongeBob. So you have this square upper body and skinny little legs. So that's pathologic. Okay? As we get older, our fat cells don't proliferate as much. So you'll see women, and I mention this because it's so easy to picture on them, that they stay lean. They're kind of a lean person. They're exercising, they're doing their thing, they're staying really healthy, and then they'll start developing fat around their belly or fat around their hips and upper thighs, their butt. Lay down. Okay? And that is not pathologic. It's just that the cells that they do, the fat cells they do have, are filling up. So they have hypertrophied fat cells, not hyperplastic fat cells. So as we age, the number of fat cells might go down. And so the fat cells that you do have are on the backs of your arms, or on your chin, or on your hips, or upper thighs, or buttocks. They're going to start getting bigger. Okay? Can you reverse that? I think yes. I think if that particular woman gets hot and heavy into high intensity interval training and sprinting, they keep their fat to protein content at 1:1, and I truly believe that person can reverse some of the cellulite that's developed, the fat that is developed. They can cause shrinking of those hypertrophic fat cells. Make sense? Remember, if those fat cells keep getting bigger and bigger and bigger, they're going to explode. But the reason they're not, and this is why I like to get an insulin level, get your insulin level. If it's high, then those fat cells are going to get completely hypertrophic and pathologic. But if your insulin level is low, it's just storing fat wherever the energy needs to be saved for a rainy day. You're not needing the fat in order for leptin, because you don't want to be fertile anymore. So that's not the purpose of that fat. But maybe that fat has adiponectin, which is an important hormone for metabolic health. It's metabolically better. What else can you do besides HIIT and besides your 1:1 ratio? You could do cold therapy. And you say, well, what is that doing? Well, there's been some studies that indicate that if you submerge yourself in cold, or you expose yourself to cold therapy, like showers or the weather, like going outside, and exposing yourself to cold therapy, you can convert some of your inactive or metabolically slower fat, the white fat, into a more brown fat, which brown fat is metabolically active. It's so active. It's what's on babies. Brown fat is metabolically active because of the number of mitochondria. White fat is hardly has any, it has a low amount, if any at all, mitochondria. So it's just kind of a blob. It's not metabolically active. It still reproduces hormones, and many of those we need, but some of the hormones are the devil too. So we got villain hormones from fat, and we got hero hormones from fat, like adiponectin. A villain might be the TPA inhibitor number 1. It all just depends on, what's going on metabolically in your body and what your insulin level is, what your triglyceride levels is, what your HDL. It's all goes together. It all has a root cause, and we need to, keep all of that in mind. Okay, so if you back to the fat transition your fat, white fat to brown fat, it won't completely get brown, but it could get beige, and it becomes more metabolically active. And cold therapy has been shown to do this. Ruth asks, what? Oh, Dennis, I will get to that. Let me just comment on this. Ruth says, what temperature do you recommend for cold therapy? Well, I can't remember. I believe it's in the 30s, Ruth, but I would have to look it up. I have never done cold therapy. I mean, you are obviously from Iowa, so for me, the way I do it, instead of exposing myself to either cold showers, which I can't stand, or obviously submerging myself in a cold bath, I mean, sometimes I think some of the pools around here that are, I think in the 80s, are too cold for me. So I don't like to submerge myself in cold water. But maybe going outside, that I can do. I can, go outside and expose myself. And I don't want to get frostbite, of course. So I'm going to expose my skin to cold that won't cause. So maybe I need to put on a lighter jacket. Maybe I need to bundle up less and go out and expose myself to cold in the wintertime. And that will help to convert some of my white fat to brown fat, as long as I'm not eating a bunch of insulin provoking foods, which I don't. Hopefully that makes sense. Dennis says, I love comparing your waist size to your height to help with identifying if you have fatty liver. Of course, but Dennis, you should be able to look in the mirror. Stand sideways and look, or look down. If you cannot see your toes or other things, then you likely have fatty liver disease if you're a man. It is obvious, but the reason why you want to do the measurement is if you're going to change things, say you're eating a standard American diet, okay? You're eating a bunch of polyunsaturated fatty acids, processed foods, sugars, the whole 9 yards. And you initially take a reading. You take a measuring tape, like a Taylor tape. It's that soft that can wrap around easily. You lie on it and wrap it around you at about the level of your belly button, umbilicus. So you measure right there. And let's say you measure again in a month and you want to see, has my waist size gone down? Am I losing 2-3 inches? The scale might not show it, but your waist circumference will show it. And so your waist should not be equal to your height. If you're 72 inches tall, let's just say 70 inches tall, your waist should not be 70 inches wide. It should not even be 35 wide. It should be less than 35. You want that waist to height ratio less than 0.5. You half. So if you're 70 inches tall, you want it less, you want your waist in inches less than 35. Hopefully that makes sense. So measuring, that helps. It helps you stay on track. Those are small victories for you. If you go from a 35 down to a 33, that should indicate to you a small victory. Then you get an insulin level and it went from 14 down to 9, small victory. All of these little victories add up and encourages you to, keep going. Dennis says, what about saunas? What about them? What are you asking about? Are you talking about red light saunas? What kind of saunas are you talking about? Because I think there are, if you're just talking about, I'm going to get in just a heated sauna, and then are you going to go back out into the cold? I think anytime that we transition from heat to cold, or vice versa, back and forth, we are stimulating brown fat or beige fat production. It might not be the extremes, but I think that you're getting some transitioning of white fat to beige. Now, if you're mentioning just in general terms, saunas, like a infrared sauna, and we're talking about heart disease or the prevention of heart disease, studies are getting stronger that indicate that there is a positive to doing infrared saunas, because the infrared light is increasing nitric oxide production. Nitric oxide is a vasodilator for arteries, causing them to expand and get bigger, which increases blood flow, which increases oxygen to cells. It increases hemoglobin to cells. But we have to have healthy red blood cells carrying good oxygen and carrying hemoglobin. They have to be healthy, right? So would any amount of infrared light help? It just goes back and forth. I don't want to say one way or another, but an infrared sauna can't hurt. How about that? And if you have the means to either buy one or go to a spa that has one, I think do it. Okay? You could also go sit out in the sun. I mean, sun has infrared light as well. It has visible light, infrared, and UV. So it has the 3 types of light that you're exposed to. So sun helps. Good questions. Yeah, Dennis does, yes, infrared. There was a study, Dennis, after a heart attack. So when people have a heart attack and they go into the hospital, they saved you, because 50% of the people won't make it, but you were one of the 50% who did make it and get treated, and you lived to see another day. They put you on medications that help nitric oxide be released. They might put you on a calcium channel blocker, a beta blocker, an ACE inhibitor. They're going to put you on blood thinners. They're going to do all of these things because all of those medications have indications or mechanisms of action that help you initially after a heart attack. Even if you've had coronary artery bypass graft, they're still going to put you on these things, these medications, in order to prevent a recurrence of a heart attack, because most heart attacks occur in the first few days to weeks after your initial heart attack. That's why they put you on all these medications. And there's a study, I believe it's on Dr. Stephen Hussey's website, and it goes into how sitting in an infrared sauna will do all of those things that all of the medications do. He actually did it. He did not take any, or so he says, he didn't take any of the medicines after his heart attack. His heart attack was caused by a blood clot. I don't believe his arteries were plugged up, but you guys can check me on that. What do you know about Tesla med beds? Not a lot. I don't know a lot. Sometimes, Danica, sorry. Maybe it's Danica. I don't know. Young. Sometimes I wonder if we are being manipulated, kind of like shots. If we get, or exposure, we're exposed, not even get, but what if we're exposed to a certain virus and then we're told to get a certain injection in order to live? That will be why you do it. Well, why do I need this? Well, so you don't die. Well, here's the news, you guys. You are going to die. It's just that when. And when you do die, where are you going? So is is this of God or is it not of God? I think that's where I'm trying to go with this. You might say, well, God gave the man the smarts in order to make the thing to put in us that will cause us not to die. All right? You could take that argument that, well, it was God that blessed that guy with the smarts enough to make the thing, to do the thing to prevent you from dying from the certain virus. I'm not so sure, but I could go both ways on that. Is I think God will use whatever it is, if it's evil or if it's good, he will use it to his glory. So even something so bad, so evil, God can use for his glory. But when we start thinking and believing man that he can save us, or she, you know what I'm talking about, human. If we start believing humans that they can keep us from dying, we are actually saying to ourselves that God made a mistake. That's in my book. You might not believe it at all. And so, no, I don't think you should just give up on yourself. I truly believe that if you change your diet, you change your exercise, you change your sleep, you stop smoking, you stop drinking, you do all these things, I'm not really giving you something to prevent you from dying. You're going to die. I'm trying to increase your longevity and your quality of life. You might not see it that way, and you can take my recommendations with a grain of salt. It doesn't bother me. I'm just trying to provide you information to get you to start thinking. But if I say to you, you come into my office and you say, I don't want to die of this virus. And I say back to you, take this and you won't. I'm like acting like a God, or what I'm giving you is the God. Okay? It is not. Neither one of those things. But if you were to take this med bed, for instance, you're actually saying that God messed up. And is a med bed any different than me telling you to reverse or prevent you from getting the thing in the first place? In other words, is a med bed similar to the thing I'm going to inject you with that tells you you won't die of the virus? So if I put you in a med bed, am I going to get rid of your coronary artery disease or your diabetes? Why not just reverse it naturally? Why not get it in the first place? Why would you simply let doctor give you the injection or put you in the med bed to try to reverse and take away all the things? I don't know. I don't know the right answer. So no, I don't know much about this, but I always bend it back to the gospel and I say, what would Jesus do? What is Jesus thinking when, instead of asking Dr. Jensen, what do I think of med beds? Ask God. If you hear him saying, well, I made man and I blessed man with the intelligence to make this med bed and that's the way it's going to go and that's what I had in mind all these years, I don't know. Maybe you're hearing from God and I'm not. I don't know the answer. It just seems, I get a weird feeling whenever I think about these injections or these med beds or something that is changing us genetically and basically saying, hey, God made a mistake and go ahead and do the med bed. I can't get on board with that. But maybe you guys can. Okay? So I'm just checking to see if I missed any questions. You guys have any further questions? We went through a lot today. As a review, we started out talking a little bit about cholesterol and what it does for our body. We discussed in general how to check for cholesterol and why we may or may not want an advanced lipid test to see our particle size and particle number. We talked about calcium scoring tests and what they can show us. How often should we get them? Can we take it as if it's 0 or am I good? Possibly. Is there further testing? Possibly. We talked about all these things. We talked about insulin We talked about fat as an endocrine organ that secretes hormones, and some of those can be good and some of those can be bad. We talked about insulin not always being the villain, but also being a hero. We would die without insulin. That is a fact. I mean, look at a type 1 diabetic. If you don't give them insulin, they will die. It's just that most of the population, a majority, has too much insulin, and it's causing a lot of disease. And it's reversible if you want to reverse it. We talked about fasting and when it could be good for us and when it could be bad for us. So if there's further questions on that, ask away. You're very welcome, Danny or Danica. I'm not sure which one it is, but you are very welcome. Hopefully that answered all your questions. If there's no further questions, we'll call it good, you guys. I talked about a lot today. Hopefully it'll kind of soak in, it'll rattle around in there, and it plants seeds and gets you thinking about, hey, do I want to get some lab tests? Do I want to see where I'm at? Do I want to get a baseline? Do I want to stop smoking, stop drinking? Do I want to start exercising on a daily basis? What do I think is the best exercise? I think doing resistance training with sprinting is the best you can do. Now, that can look like different levels. My level of lifting weights and sprinting might look way different than yours, but I've been doing it for a long time. All right? With that being said, we will be back tomorrow at 10 a.m. Central Time, live stream with Dr. J's Prescription for Health. You guys have a great day. See ya.